Could I have my slides up, please? Good morning. Thank you very much to the organizers for inviting me to come and speak. It is a pleasure to be here. My name is Christina Canil. I'm a medical oncologist, and that's a fancy term for a cancer doctor who treats patients with drug therapy. Unfortunately, the patients that I see with prostate cancer are individuals who have advanced treatment. So they may be men who have received radiation or surgery, and unfortunately their cancers come back. Or they may be men who presented with their prostate cancer for the first time and it's already spread outside their prostate to other places like the bone and the lymph nodes. So I'm not going to be able, unfortunately, to get rid of their cancer completely with my treatment, but what I'm hoping to do is turn their cancer into a chronic disease, the same way that we can't cure diabetes or high blood pressure or emphysema. What I'm hoping to do is to slow the disease down and help people live longer and live better. And as Chris had said, this is not just me, it's a team approach. So I work closely with the urologists and the radiation oncologists so that we can provide patients and their families with prostate cancer the best care possible. So as Rodney had mentioned, there has been an explosion of therapies in the last few years, and it's a really rewarding, exciting time to be treating prostate cancer. And what I want to do is just briefly tell you about the treatments that are currently available, and many of them have been developed only in the last few years. Now, one of the big things is just science has caught up, and we are better understanding the biology of prostate cancer, which has allowed for development of these new therapies. So here I have a little slide that shows the therapies that are currently available in Canada for advanced prostate cancer, and there's a little bit of timeline as to when they were developed. So we know that prostate cancer uses testosterone as a food to make it grow. So the mainstay of treatment for patients with advanced prostate cancer is to try to lower that testosterone level and essentially try to starve the cancer of its food. And that's what these drugs, these LHRH agonists, and more recently antagonists do. They are very effective at keeping the prostate cancer under control, and like Dr. Morgan had said, they can work for a number of years. But unfortunately, this prostate cancer is very sneaky. It learns a way to bypass the fact that its food supply is very low. So there was a time for, that was like about 20 years where really that was the main treatment we had. It wasn't like people weren't trying to find new drugs. They were doing research, but so far everything was not effective. And it was in around 2000 when chemotherapy with a drug called docetaxel was shown to be benefit. And the leading studies were done in Toronto under Dr. Ian Tannock. And what chemotherapy is, it's medicine, usually intravenous, that goes into the vein and circulates through the body to try to attack the cancer. What chemotherapy does is it kills cells that are growing rapidly. And that's great because we know that cancer cells grow quickly. The problem is there are some normal tissues that grow quickly too. And so what happens is chemotherapy can be associated with some significant side effects that can make people feel unwell. So there's a bit of a cost that's associated for the benefit. What's been really exciting is that science has tried to learn why prostate cancer can grow despite the fact that testosterone is so low in the blood. And one of the things that they've discovered is that this prostate cancer has learned how to make its own male hormones, and that's what's driving it and making it grow. So in the past few years, there's been some hormonal treatments, abiraterone and enzalutamide, that are currently on the market that can help to stop the prostate cancer from making its own male hormones, and they use some other different mechanisms also. The nice thing about these agents is that they're oral agents, so they're pills that you take, which is more convenient, and they tend to have less side effects than the traditional chemotherapy. These agents too are shown to help people live longer and help deal with any symptoms they may be experiencing from their cancer. Cabazitaxel is another intravenous chemotherapy. It can be effective in patients who are no longer responding to the traditional docetaxel chemotherapy. And then finally, the last two agents, radium-223 and bone-targeted agents, are more focused on the spots of cancer that have gone to the bone. We know that as people get older and when they have spots of cancer in their bones and they're on these medicines that lower their testosterone levels, it makes their bones quite thin and at risk of breaking. And what bone-targeted agents are, they're similar drugs that people would take for osteoporosis when their bones just get thin because of older age, and it strengthens the bones and decreases a complication like a break or needing radiation for pain or needing surgery. Radium-223 is a brand new drug which is really exciting. It's what we call a radiopharmaceutical. So basically it's a combination of a drug and radiation treatment. So you heard from Dr. Morgan that the radiation treatment that he gives comes from the outside. He radiates the cancer from the outside. What's cool about radium-223, it's basically injectable radiation treatment. And what it consists of is a molecule called radium that looks a lot like calcium. And when you inject it, it goes to the places in the bones that are most active. So it goes directly to the spots of cancer in the bones. And what's really neat about it, it's got a little radiation attached to it. And what you're doing is taking the radiation directly to the spots of cancer within the bone, and you can treat multiple spots of cancer at the same time. And this treatment's been found to be effective to help with bone pain and can also help people live longer. So here is what we're doing. Those are the agents that I have available today in September of 2017. And just like Rodney was saying, there's a lot of new developments in the work. And when I'm talking to patients about the treatments that are currently available, it's so exciting that I have to tell patients, you know what, this is what I'm doing today, but you know, in 6 months or in a year, we may be doing something different because research is rolling along so quickly and management is changing for prostate cancer, which is very hopeful. So what are we looking at in the future? Well, in terms of these drugs that have been developed, just like Dr. Morgan was saying, we are currently using them primarily in patients that are no longer responding to those hormone injections. And what we've discovered is that if we take some of these drugs like abiraterone and taxotere and we move them earlier in disease when patients are first diagnosed with metastatic disease and first started on those medications to lower their testosterone level, it's making a significant improvement in how long people will live. They're living a year, 2 years longer than they would otherwise. And just as Dr. Morgan mentioned, trials are underway looking at moving some of these hormonal treatments even earlier in the curative stage where patients are receiving radiation, adding the abiraterone to hopefully increase the chance of curing the cancer completely. The other thing that we're looking at is maybe we could not just use all these drugs sequentially, but maybe we can combine treatments and knock down that cancer even better. So we participated in a clinical trial looking at combining abiraterone, which is a hormone treatment, with radium-223, and those results are still pending. Now, we've been very fortunate in Ottawa that we've been able to participate in many of these landmark studies. But just as Rodney was saying, it's been a pleasure to have individuals who are willing to take that risk and participate in these clinical trials, and also people like Prostate Cancer Canada and other organizations that are donating money to allow this research to happen. And the results of this research, which is done today, is going to help people 10 years down the road so we can do even better job managing prostate cancer. So what's happening in the future? Well, we're moving towards what's called personalized medicine. And what that basically means is that not every single prostate cancer is the same. One person's prostate cancer may be different than another person's prostate cancer. And one of the challenges that we have as medical oncologists is we don't know what the right order of drugs is to use. Maybe one person would benefit or their prostate cancer would respond better to a hormone treatment, while for another people chemotherapy would be a better approach to go. So there are some clues that we can look at that can give us an idea of maybe what would be the best approach for an individual. So some of those clues are clinical. So we may look at the cancer itself. Is it an aggressive cancer? Does it have a high Gleason score? Did this cancer respond well to hormonal injections, or did it progress very rapidly? The other thing we look at is obviously the patient. How fit is the patient? Are they a very active person, or are they spending most of the time in bed because they're feeling quite unwell? Do they have other medical problems that may preclude them from having certain treatments? And also patient preferences. Patients may hear about this information and think, you know, I really want to have a drug that I can take by mouth and I can travel and not be so concerned about intravenous treatments. So obviously, they're part of the decision making, and it's the decision making between the doctor and the patient and the family together. But what we're really working towards, I think, in the next few years is looking at the genes or the blueprints of the cancer. DNA is the building blocks of all molecules. And what we have learned is that there may be some special features within the genes of the prostate cancer that may help us pick drugs that work better for certain individuals. So what we're specifically looking at are mutations or errors or mistakes in the DNA. So for example, we would look at the prostate cancer cell and do a test to see whether or not they have a mutation, which is called ARV7. So ARV7 stands for androgen receptor variant 7. So the androgen receptor is a little flag that sits on side of the prostate cancer, and that's important for interaction between testosterone and male hormones, and is also important for drugs like abiraterone and enzalutamide, those hormone pills, to work well. Well, if you have this variant, maybe enzalutamide and abiraterone won't work well, and you're better off going on chemotherapy instead. The other area of mutation which is looking very promising are DNA repair mechanism mutations. So the body has ways to make corrections when there are breaks in the DNA strand. And what can happen is that those systems can break down. And what we've found that there is probably 1 out of 5 individuals with advanced prostate cancer has this sort of DNA repair mechanism mutation. And there are certain drugs which are called PARP inhibitors that can be very effective. There's a drug that's called olaparib, which is coming down the pipeline, which looks very promising for this patient population. The other thing too we learned is that, like ovarian and breast cancer, people who have these DNA repair mechanism mutations are more likely to respond to a different type of chemotherapy called platinum. And there are other mutations that are being identified, and research is trying to develop drugs to monopolize those mutations. And what we're hoping in the future is to be participating more we call basket studies. So obviously, this is difficult research to do. There are not a lot of patients who have these mutations. They probably count for 5% for each of these individual mutations, but they do add up. And what we're hoping to do more on a national level is, as a Canadian group, participate in some big studies where we send prostate cancer samples to a local lab, for example, Vancouver, who's very active in that. They would look at all the samples and find the mutations, and there would be different trials all over the country that people could participate in. We may not have all the trials in Ottawa, but maybe we have one trial in Ottawa, another trial in Montreal, another one in Toronto, so that patients can get access to these uncommon drugs, but can be very effective for them. The other thing which is coming to fruition is, now that we're doing more testing of the genes, is we're finding not only mutations that put people at risk for cancer in the prostate itself, but in some normal cells. And what we're finding is that there's individuals who have these germline mutations which may predispose them for developing cancers such as prostate cancer, and they could pass that on to their family members. So for example, BRCA mutations, which we know about with breast cancer and ovarian cancer, are also associated with prostate cancer and pancreatic cancer. So if some of our patients with advanced cancer, when we're doing this gene testing, we're finding out that they have some mutations that may be important for their family members who are at risk for developing prostate cancer too. And then just briefly, I wanted to mention immunotherapies. So there's been research in the past looking at prostate cancer and also other cancers. The fact is that cancer is so sneaky and it kind of flies under the radar, and the immune system doesn't recognize it. So there's been some drugs developed that sort of unmask the prostate cancer so that the body can see it and the immune system can attack it. So there's some agents called immunotherapies that we're participating in clinical trials with prostate cancer patients, seeing if we could rev up that immune system to attack the cancer. So in summary, the message I hope I can convey to you is that there are multiple new therapies in advanced prostate cancer. These drugs are being assessed earlier in the course of disease in combination, and we're trying to figure out the optimal sequence. In the future, we're going to be looking at personalized medicine, identify mutations that make the cancer cells grow, find the right drugs for those mutations, and have a better understanding of hereditary prostate cancer. And immunotherapy may be playing a role in the future also. Thank you very much.